welcome everyone to another episode of Talk with a Doc. My name is Janvi, and throughout this series I will be talking to doctors of different specialities and those at different stages of their medical journeys to learn more about the variety of opportunities within medicine. In today's episode of Talk with a Doc, I am going to be talking to Dr. Rajeev Prasad, a pathologist working in Queen's Hospital in Romford. Thank you so much, Dr. Rajeev, for joining me today and for giving up some time to talk about your career with me. To begin with, what does the job of a pathologist actually entail?
Thank you, John V, for inviting me to this wonderful discussion or interview, you could say. Being a pathologist, the most important thing for our job is to diagnose tissue, diseases based on the tissue diagnosis. So what happens is, like a patient, for example, a patient presents with like lumps or bumps or any conditions, and the surgeon or the clinician, he thinks, okay, so let's take a tissue diagnosis, because it's very difficult to say the disease, the nature of the disease, just like, on a visual examination. And even at times with the radiology, you cannot reach to a conclusion. So this is where our role comes in. So what we do is we process the tissue in the lab, look under the microscope, and then give a diagnosis. So the broad thing is whether the disease is inflammatory or benign lesion, or is it malignant or any cancer. And then, based on our diagnosis, the clinician, he would proceed further. He would give the adequate treatment to the patient. So this is what our role is, basically.
That sounds really interesting, and a very unique line of medicine where it's more lab-based than necessarily patient contact hours. What attracted you to this speciality in particular?
Yes. So the main thing is the nature of the disease, or you can say the underlying conditions, the disease process itself attracts me. So for example, when I was seeing patients, and then when you read about a particular disease, so you start going into detail, how it originates, or how the disease progresses. So that is something very, very fascinating. To understand the entire the disease process, how it goes. For example, a very simple example is the coronavirus, which is the world is facing at the moment. So we all know what coronavirus is doing to our body, right? But then how the virus behaves, or how it happens, how the disease progresses, and what are the underlying conditions. So that is something which is more fascinating, and which is more curious to know. So that drove me to to take up pathology in future. When I was studying medicine.
That's really useful, and of course, yes, very relevant at the moment. I'm wondering, just out of curiosity, how would you enter the line of training to become a pathologist? Because as we've discussed, it's slightly more less clinical based and less sort of patient contact hours, more working in labs, working in a more academic setting. So how would you enter that line and specialize in pathology?
Yes, so pathology doesn't allow you to have a more patient contact, in terms of you don't see patients. So that is one thing which you've got to be very, very clear when you take up this specialty. Although, having said, there are a few areas in pathology, for example, the fine needle aspiration, which we do, which we see on the microscope. So in various hospitals, what they do is the pathologists, they take the needle aspirates from the patient. So you do have a bit of a patient contact, in the sense you go and you take the sample yourself. For example, a patient present with a neck lump, right?
Okay.
For any thyroid conditions, a patient presents with a goiter, and there's a neck lump, or any cyst with a neck lump. So in certain places, the pathologists, they take the history, a brief history, they examine the patient, and then they take the needle, they insert the needle, they take the sample. But in most of the hospitals, this is not done by the pathologist. So by and large, like the pathologists, they don't usually see the patient. So this is
Right.
something which any trainee who wants to pursue pathology as a career needs to be very, very clear about this fact. Now, most of us, our job, yes, it is lab based, but we work as a team. Like, for example, although we don't see the patient, but then we discuss around the patient. So there are like, yes, so there are time to time, like, we have these multidisciplinary team meetings, what we call, like, where we as a pathologist sit along with radiologists, oncologists, and the surgeon and the nurses, like the specialist nurses, and the team managers. So we all, like, discuss around the patient cases. Each patient is discussed, and based on our input, like, the management is decided, and that is how, like, the patient is being treated. So yes, we don't have patient contacts, but then it's all about, like, working for the patient.
Of course. So even within your role as a pathologist, it's still under the the tree, which is medicine, and everything's
Yes.
centered around the patient. Great.
Yes.
Personally, what is your patient contact hours like? Do you have any at all, or is it very limited?
Personally, no. Personally, I don't have any patient contact.
Okay, no, that I thought, as you said, that some would have some patient contact hours, obviously, if you're working alongside the cancer patients. But yeah, that's really interesting. I didn't know there was a branch of medicine which could have no patient contact hours at all. So within your role as a pathologist, what are some of the challenges of your jobs? Do you ever have to break bad? I mean, you don't clearly have to break bad news to patients, but do pathologists in other fields, as you said, who do have some contact with patients, would they ever have to be the ones to break bad news to them?
No. So bad news is not broken by the pathologist, like,
Okay.
yes. So it's the clinician who does it. But then, having said, it's the bad news which we probably give at times, because the patient has a cancer, and then it's basically our report which the clinician tells the patient based on our findings, based on our report. So indirectly, yes, we are involved in breaking the bad news, but it's not like, no, we don't tell the patients directly. Because most of the time, if a patient has a tumor, then like, we do tell in our reports, like, what type of tumor it is and how the tumor is going to behave. So based on our report, based on our findings, the clinician let the patient know.
Okay. Sometimes, as you said, when some clinicians can't figure out what is wrong with the patient through their simple scans, they turn to you. So is it often difficult to be able to pinpoint what exactly is wrong with the patient?
Yes, definitely. This is where, like, the pathologist role comes in, and our role is more like a gold standard, like a diagnosis, because the tissue diagnosis is the gold standard diagnosis for a particular disease. So, for example, what happens is the radiologists, because radiology is a non-invasive, so you don't, like, take any tissue, you don't penetrate into the patient's, you don't prick something, or you don't take a biopsy. So so radiologists, they can tell, like, okay, fine, there is a lesion here based on what he sees. And a number of times they can say that, yes, this can be malignant, this can be benign. But then there are, like, limitations as well for pathologists, because it's a non-invasive, so you don't actually see based on the tissue. So this is where we, we provide an important service here, because based on the tissue, we tell them, yes, this is a cancer, and what type of cancer this is, how the cancer is going to behave. So this is how, like, if the clinician has a little bit of doubt also about the particular disease, he gets a proper confirmation, and then based on that, he will treat. For example, I can give you a very good example, like, a number of times, which happens with me, on a routine basis. So, like, for example, the patient presents with a rectal lesion. Okay, there's a rectal polyp, and radiology says, okay, fine, he can see that there is a lesion, most likely it is a malignant tumor. But then a number of times, the clinician, they have to wait for our confirmation to say that yes, well, this is cancer or not, because a number of times it cannot be a cancer. It can just be a pre-invasive a cancer. Something like, a pre-invasive cancer is something where the disease is still in the process and it is just about to probably become cancer, but it is still not a full-blown cancer. So now this has got a very important implication based on the diagnosis, because if when we say that this is cancer, then for any rectal lesion, the patient is undergone given chemoradiotherapy, right, and not straight to surgery. So yes, so and chemoradiotherapy is a very, very important, from the management point of view. And if a patient doesn't need a chemoradiotherapy, and if the patient is given, so it comes with all this, the pros and cons. So that is how, where the clinician has to be very, very sure from the pathologist perspective that this is cancer, and then he can go ahead. So that is one thing.
I see just how vital your role is, because of course there's a dependent on you as a pathologist to then take the next course of action, depending on what you're able to sort of diagnose on a molecular level.
Yes. Yes, and also and also, for example, another very good example is a number of times the clinician he thinks that, oh, this can be a cancer. The radiologist thinks that this is a cancer, and when we look under the microscope, we know that this is not cancer, but yes, this is malignant. But that is something called lymphoma. Lymphoma is something to do with the it's completely a different entity compared to routine cancer, and the patient management again is completely different. So there you go. There you can see, based on our report, based on our findings, the patient is completely managed differently. So that is how vital, our role is.
Definitely, I can completely agree with that, and I'm sure it must give you a lot of job satisfaction as well to know that thanks to you, patients are diagnosed correctly and they're having the correct and personalized, patient-centered care for their specific condition. What other merits come along with being a pathologist? Job satisfaction is a main one I can see evidently, but what other merits are there to your job?
Well, the merits, if you see what can be, let's say, for example, a demerit can become a merit in terms of pathology, for example, where we don't have a patient care. So our job is like so-called 9 to 5, although it's not exactly 9 to 5 job.
All right.
Unlike another the busy clinical specialty where you have to work in shifts, or it can be exhaustive physically. So although it's not exactly 9 to 5, because we do have to stay back late hours at times, but then it can be more flexible as well. Our roles can be flexible because we're not seeing the patients. We don't have to meet the deadlines in terms of okay, fine, at this particular time you have to see this particular patient. So that way you can. A number of times, the other thing what we see is if, let's say, for example, because see, all diseases are not very straightforward. Okay, they don't read the books and they come. So they can be we do encounter some very, very difficult diseases at times. So what happens is when we come through a difficult case, for example, then we can just put aside that case. Okay, I'll do it some other time when I'm more fresh or something like that, and then get on with the other cases. Whereas when you're seeing a patient, you're stuck with an important something. You can't just leave the patient aside and say, okay, I'll come back and treat you some other time. So this is another which is good the thing, and I think the overall thing is the job satisfaction which you get. And also another thing is the networking, which you build up with all your team, because your surgeons, your oncologists, and everyone looks up on you in terms of you know that yes, you're very important to them,
Of course.
based on your report. Like, everything is going to to be managed. So that is another big satisfaction which you get.
Sounds like a great career to go into for, quite a few. I know lots of people in my own year group, for example, who definitely love the idea of medicine, but perhaps want to take it in a more academic approach. So this does sound like a really great line for that. And you talked about work, your work hours, and that how it sort of fits more in the 9 to 5 sort of category rather than shift work. But of course, you said sometimes it can go over that. So I was just wondering, with this specialty, would you say it's easier to maintain a good work-life balance than perhaps another specialty within medicine?
Oh yes, definitely. Anytime I would say this, you can maintain your work-life balance very well. For example, you don't do weekends. I
Oh,
don't
right.
have to I don't have to go on a weekend. But then, as a trainee, when you're training, definitely you can't. You have to there were times when even on the weekend we used to go look at the slides, look at the cases, read around. So that's completely different. But when you become a consultant, and then you're more in control of your work, then yes, it becomes much easier.
Mhm. Talking about becoming a consultant, how is it like to specialize within pathology? Are you able to sub-specialize into specific types of, I'm not sure how it would work exactly. Do you
Yes,
mind talking me through that?
yes. Because it's a broad thing, pathology. To be honest, when you're training, you have to uh, look at everything, all the diseases in the body, right from gynecology to urology to
Mhm.
gastrointestinal diseases or head and neck, everything,
Mhm.
right? But then once you become a consultant, and also depending on which hospitals you work in. So, for example, in a teaching hospital where it's more specialized, so there is some subspecialization where you take up one or two systems, and then you specialize in that. You look into mainly into those systems. So I also because ours is a very big it's a secondary hospital. So what we do is we also specialize. All the consultants there, they do subspecialize. So I look at the GI, the gynae, and the head and neck cases.
Right. Okay. Sounds really useful. I didn't think, I wasn't sure, because obviously it's very much lab-based, how the specialism would work and how you would be able to choose which kind of area to look in. But it's basically similar to any other specialty in medicine where you can choose, like the other specialties, which type of tissues and things you look at.
Yes, absolutely.
Great.
Absolutely.
So I was just wondering, what would a day in the life look like as a pathologist? Say, for example, if you go and work Monday morning, would you be in the labs all day long, or how would that look like?
No, Janvi. We don't be in the lab most of the time. So in the lab, our main job is just to do the cut-ups.
Oh, I see.
Cut-up is basically gross examination of the specimen. So I'll just go through how it works, the histology works. So the surgeon will send you the sample, right? The sample can be of a smaller tissue, which is the biopsies, or it can be a major resection, for example, if someone has got a colon removed, or someone had a mastectomy, right, or someone had a hysterectomy, so they will send all those specimens. They'll come in big buckets, right? Now, so what the lab does, the laboratory staff, where we've got the biomedical scientists, so they do all the processing, right?
Okay.
When the bigger tissue comes in, the resection comes in. Now, for example, let me tell you, if let's say, for example, if there is a mastectomy, right? So the entire breast is sent to you. Now, it has been done for a tumor. So you cannot sample the entire breast, right? Because it's a big specimen. Or similarly, the colon, you cannot sample the entire colon. So there is our role of gross examination. So when we specimen, when we slice into the specimen, okay, then we look at where the tumor is,
Right.
right? And so instead of sampling the entire thing, we just sample from the site of the tumor. So we take the relevant blocks. So this is something which the biomedical scientist or who hasn't been trained will not be able to do this unless like they've been trained. So we take those relevant blocks, right? So those samples, they get into, we call them cassettes. So we put them in small cassettes, okay? Then they go into the machine where it gets processed. So then it comes out of the machine. So next day, like, they are cut by the microtome. They're into very into 3 microns, slices, and then they are taken on the slides, the glass slides, right? Those tissues, and then they are stained, adequately stained, and then they are given to us.
Right,
So
I see.
then we look at those slides. So our job is, yes, so our job is first in the gross examination to take the relevant blocks, and then finally to look at the slides, the prepared slides.
Right, that makes much more sense. So all the processing is done by the biochemists. Your job
Yes,
is to choose the correct
biomedical scientists.
specimen.
Yes. So they do everything. So we don't have to do those aspects.
Ah, I see. That makes much more sense to me now. Very interesting. Okay, so as well as working with other doctors, you're also able to work with biochemists. So you have a lot of connections.
Yes. We have a lot of interaction. Yes. Absolutely.
That's really great. One more thing, I was just wondering why would you choose entering pathology, say for example, over becoming an academic doctor and staying primarily in research? What made you choose that line over the other? Because they sound very, very similar.
They yes, but they're not very similar, to be honest. Yeah, they do sound similar, but see, the thing is, for something for research, that is a completely different, branch of itself. It's completely different track, where like you're not more into tissue diagnosis. You're more into the molecular level, and you're doing other things you're trying to understand how this particular tumor behaves. So all this, whereas ours is providing services, right?
That makes
so
sense.
rather than doing the research, we provide services to the patient, to the clinician, right? And the best thing with us is it's got both the things. If we want you, for example, when you're training, you can take some time off and do some research work as well. From the entire training period, you can just take off 1 or 2 years and do some research work as well. So if you're keen to do that, you can do that. The other thing what we do is you can publish papers by being what you are, by doing what you do. So, for example, recently I did publish something, and there's another one which is being published. So it is the surgeons, they did a pelvic exenteration where they took out the colons, they took out the uterus, bladder, a bit of bone. It was for a cancer. So that was something very, very challenging and interesting, although not interesting from the patient point of view, but a difficult one. But it's at least these are the ones where if you do it now, then it becomes better for for the future.
Great.
So you can have both the worlds by being a pathologist.
Wonderful. Yeah. So there is definitely a lot of opportunity to subspecialize and also cross over with other branches of medicine.
Yes.
This sounds like a really interesting line of medicine, and definitely one that I'll think about more now. Finally, I just wanted to know, is there any advice you'd give to students like me who'd want to enter medicine, and then specifically if there's any advice you'd have for pathologists in particular?
Johnny, you I think you are highly motivated. So I'm pretty sure over the period of time, you'll make up your own mind what you want to become. And the good thing about medicine is you are exposed to various specialties while you're being trained, and where you can make up your own mind. Because if I say something to you now, it'll be like, too premature, I would say, because unless you have tasted the various specialty, you will not be able to make up your mind. So the good thing what you're doing is by talking to various people, like various consultants in their specialty, and then you getting more about it. At least you, I would say, you have an informed choice at the moment. What other specialties their roles are. Who knows, in future, once you, for example, once you've done your medicine, because these are all post-graduation, you need to bear in mind, for the entire duration of your MBBS, you have to study everything, right? So when you come to that level, you'll be more mature to understand, what you want, and then you will be able to, make your decision. I'm pretty sure. I know you will be able to make your decision at that point of time.
Great, thank you so much. I think the biggest takeaway I've had from this is, one, I've learned quite a lot about your specialty, but also the idea of keeping an open mind and being open to any opportunities that are given along the way, which is fantastic. So thank you so much, Dr. Rajeev. It was really useful talking to you today, and I've definitely learned a lot about your specialty.
Thank you, Janvi. It was really a pleasure, talking to you and seeing how motivated you are. I wish you good luck in future, and may God bring you all success.
Great, thank you so much.